So we are starting today the medical kidney. Medical kidney, just letting you know that it has a big bunch of questions in the Q banks, and also you might get a couple of questions in your boards, of course. Although I had the previous board takers, they told us that they got a lot of medical kidneys in the exam, interestingly, but I believe maybe this was a coincidence. However, it's one of the boardable topics. For some reason, a lot of people or a lot of people like feel like the medical kidney is hard. Although for me, it's very step one pathology relevant. However, you can add some extra stuff for step two. So I honestly never struggled in the medical kidney part. Although they claim that it's extremely subspecialized, yeah, I know it's tough to deal with medical kidney biopsies, extremely subspecialized and need a GU specialist. However, I mean, board-wise, questions-wise, I never used to struggle in the medical kidney, and that's what we are planning to, or that's why what we're planning for after these sessions, after these couple of sessions. So let's get started with our outline. So the outline, we will go over the glomerulonephritis, of course. This includes actually the first four topics of the outline: the nephrotic syndrome, the nephritic syndrome, the asymptomatic hematuria / proteinuria, which is actually part of the nephritic syndrome. And there is an entity which can present, or some GN entities, glomerulonephritis entities, which might present with both nephritic and nephrotic. So it's a kind of overlapping entity. It might present as both. And then we will go over the tubular diseases, interstitial diseases, and vascular disorders of the kidney. So all the medical kidney doesn't have any cancers, no tumors. It's pure medical conditions. That's the first couple of slides, or that's the first couple of diagrams. Are actually took these diagrams from my step one notes. That these are the types, or the two types of glomerulonephritis that you will see. You have two types of glomerulonephritis, which is an inflammation of the glomeruli. So if I'm talking about inflammation, so it's either acute inflammation or chronic inflammation. So we're having acute glomerulonephritis and chronic glomerulonephritis. The acute glomerulonephritis is the one that presents with nephritic syndrome, and the chronic glomerulonephritis is the one that presents with nephrotic syndrome. And that's why I used to say that nephrotic is chronic. Nephrotic is chronic. So that you remember that chronic glomerulonephritis is the one that presents with nephrotic syndrome, and the types of acute glomerulonephritis are the ones which present with nephritic syndrome. What's the difference between nephritic and nephrotic? Both of them represents renal injury or kidney injury. So you will have elevated renal functions, or elevated BUN and elevated creatinine, which are the renal functions. Elevated renal functions plus, what are the clinical manifestations of chronic glomerulonephritis / nephrotic syndrome? So in nephrotic syndrome, you have injury of the renal glomeruli, chronic inflammation of the kidney, or chronic inflammation of the glomeruli. The chronic inflammation usually affects the glomerular basement membrane. And this glomerular basement membrane is the key element which prevents the filtration of the proteins. Because as you know, the glomerular basement membrane has negatively charged molecules. It has negative charges. The negatively charged molecules are some kind of heparan sulfate molecules and some kinds of glycosaminoglycans. These negatively charged molecules and the filtration slits which exist in the glomerular filtration barrier are the ones which prevent the filtration of the proteins and the proteinuria. That's why when you have the main injury in chronic glomerulonephritis is happening in the GBM or the glomerular basement membrane, you will have heavy proteinuria. So you're getting severe proteinuria. When you get severe proteinuria, all the proteins are getting out in urine. So this will lead to decreased proteins in the blood. This is what we call hypoproteinemia. The hypoproteinemia will lead to decrease in the oncotic or osmotic pressure, which sucks the water and keep it inside the vessels. So when you decrease the proteins, the water will start to escape from the vessels to outside, and this will lead to severe edema. And with the decrease in the proteins in the blood, the liver will get mad. While the proteins are decreasing in the blood, the liver, as you know, is the source of the plasma proteins in the blood. So this will lead to reactive increase in protein synthesis by the liver. However, the problem is when you turn on protein synthesis in the liver, you turn on lipid synthesis as well, because liver usually synthesizes lipoproteins. So when you turn on the protein synthesis, you turn on the lipid synthesis as well. And this will lead to hyperlipidemia, which we call it reactive hyperlipidemia, because it happened due to reaction of the liver to the hypoproteinemia happening due to the heavy proteinuria, happening due to the chronic injury of the glomerular basement membrane and loss of the charge barrier. So we're having reactive hyperlipidemia, and they sometimes say lipiduria. Sometimes these lipids, because they increase in the blood, they end up going down in urine, and you have severe edema. And also you start losing some essential proteins like the coagulation factors. You lose the coagulation factors in urine. This leads to you lose the anticoagulation factors like the protein C, protein S, antithrombin 3. These proteins, you lose them in your in urine, so you end up having hypercoagulability, or the patient end up having hypercoagulability, and also you lose the gamma globulins, which are the antibodies, because they are also plasma proteins. So when you lose them in urine, so you are losing antibodies, so there is high risk or recurrent infections in patients with nephrotic. So we have a nephrotic syndrome, severe proteinuria, severe edema, hypoproteinemia, reactive hyperlipidemia, hypercoagulability, and recurrent infections due to chronic glomerulonephritis causing injury of the glomerular basement membrane with loss of charge barrier. However, what happened in acute glomerulonephritis is totally different. This represents sudden, severe acute injury to the glomeruli. This leads to damage of the glomerular epithelium/endothelium, as well as the basement membrane. So what you end up having as a significant manifestation is actually hematuria, with decrease in the GFR, decrease in the filtration, and oliguria. There is proteinuria, but the proteinuria is mild, because here the injury is severe enough to the point that you are getting oliguric patient. Actually, the patient is getting oliguria, and there is not that much urine output, not that much protein is going out. So the patient will have mild edema with significant hematuria, mild proteinuria. So hematuria is bleeding. Bleeding equal severe, sudden damage, which is acute glomerulonephritis and nephritic syndrome. Both of them, you end up having one of two outcomes, which is actually recovery or renal failure. Recovery or renal failure, it depends. And this one will lead to acute renal failure, and this one would lead to chronic renal failure, potentially. So we have two types of glomerulonephritis, as I mentioned: acute glomerulonephritis, chronic glomerulonephritis, and the acute glomerulonephritis is the one that leads to nephritic. The chronic glomerulonephritis is the one that leads to nephrotic. So what kinds or what are the flavors of glomerulonephritis that belong to acute glomerulonephritis, and what are the flavors of glomerulonephritis that belong that are included in chronic glomerulonephritis or nephrotic? Just telling you something. Let's start with nephrotic syndrome and the entities of GNs which are included in nephrotic syndrome. So as I mentioned, pathology for nephrotic is chronic glomerulonephritis. You have heavy proteinuria, hypoalbuminemia, severe edema, lipiduria, and reactive hyperlipidemia. And the site of damage here is the glomerular basement membrane with loss of charge barrier, and also the filtration slits and the food processes of the podocytes. Here are the disorders that are included under chronic glomerulonephritis / nephrotic. I always say that, yes, I always say this mnemonic when I explain this stuff for the USMLE. So I will ask Abdurrahman. So Abdurrahman, which one should scare you more? Sudden severe damage or long-term damage? Which one will look more scary? The sudden severe damage or just the long-term damage?
The sudden severe damage, at least
Yeah,
the way you are saying
yeah,
it.
this is the way I always memorize which entities are included in nephritic and which entities are included in nephrotic. So when you look at the name of the glomerulonephritis and you get scared, or a word in the name make you scared or make you afraid, this means that it's sudden severe, it's acute. Like for example, see that acute post-streptococcal glomerulonephritis means sudden severe. So this is scary. So this means acute nephritic. See, rapidly progressive glomerulonephritis. Oh wow, it's rapidly progressive. So that's acute glomerulonephritis. It's definitely nephritic. Diffuse proliferative glomerulonephritis. It's diffuse. It's involving all the glomeruli. So that's very scary. So this means it's acute. It's nephritic. And you have the AB. So scary AB. Scary AB means acute post-streptococcal, rapidly progressive, diffuse proliferative, and then the AB, which are two syndromes. I always say Alport syndrome and Berger syndrome or Berger disease. AB, Alport, Berger. And then look at the nephrotic entities, or the entities which are mainly included under the chronic glomerulonephritis or nephrotic. See, membranous glomerulonephritis doesn't have any diffuse, doesn't have any acute, doesn't have any rapidly progressive, doesn't have any scary word. So it's chronic, it's nephrotic. See, minimal change glomerulonephritis, that's minimal change. See, so it's minimal change, so this means it's chronic. Diabetic nephropathy, oh, definitely that's scary, but you know that diabetes is a chronic disease and it leads to chronic damage in blood vessels. So you definitely know it would be chronic glomerulonephritis and it's nephrotic syndrome. Then focal segmental glomerulonephritis. See, focal segmental. So it makes sense. That's focal and segmental. It doesn't look scary, so it's chronic nephrotic. Membranoproliferative is actually the one which should be included under both. And this is the one that I'm going to explain in the next session. Okay, so now we got it. We know now how we can differentiate which one is nephritic, which one is nephrotic, which one is acute, which one is chronic, which one is scary, which one is not scary. So let's start now by nephrotic. We already mentioned this slide, and see the disorders that you need to know for your boards. For the nephrotic syndrome, you need to know the minimal change disease, focal segmental, membranous, and diabetic nephropathy. Let's start with these four and go over each entity separately. Let's start by the minimal change disease. You need at first to try to use the name for your benefit. You need to see what kind of information you can memorize from the name of each disease. So we have minimal change. So you need to conclude that this means that this disease involves a minimal change in the glomerular structure. What kind of minimal change that happened? Just the food processes. See the food processes of the podocytes, they got effaced. They got erased. That's the only minor change which happened in the glomerulus. This minor change, can you catch it on light microscopy on H&E? Anybody say yes or no?
Definitely not.
No, because this is very, very, very microscopic change. So you can't catch this change except when you look under electron microscopy. And that's why those who specialize in medical kidney and GU, they still rely on electron microscopy. They are the ones who still rely on doing an EM preparation for each slide of medical kidney and look under the electron microscope. So for the electron microscopy, you will have effacement of the food process. This is the kind of minimal change that happened. And there will be no abnormality on H and E. This happened in pediatric population, the minimal change. I always say minimal is for those who are minimal or those who are small, the pediatric population. And it happens as a reaction, immune reaction to a drug or to a recent infection. It leads to effacement of the food processes of the podocytes, and it leads to nephrotic syndrome. However, you need to remember that the proteinuria here is kind of selective proteinuria. Anybody know what does selective proteinuria means? What does selective proteinuria means?
Only albumin.
Yes, it doesn't include all the plasma proteins. Not all the plasma proteins go down in urine. It includes only the smallest plasma protein in terms of size, which is the albumin. This shows dramatic response to steroids. You need to remember that. And also you need to memorize this picture. It comes a lot in questions. See, with the normal food processes, you have urine only getting filtered. But in minimal change disease with effaced food process and loss of filtration slits, which are actually formed by the podocyte food processes, you end up having urine plus protein, mild, or I'm saying heavy proteinuria. However, it's heavy but selective. Minimal change, no abnormality on H&E. The second one is focal segmental. Remember, it's not scary. So the first two words are focal and segmental. You need to know what this means. So here is the glomerulus. Here is the whole glomerulus. And here is the area of glomerular pathology. That's how a normal glomerulus look like. A normal glomerulus will have spaces with visible capillaries and visible mesangium. That's how a normal glomerulus look like. But see, this is the area of abnormality. So you have a focal affection or segmental affection of each glomerulus. So that's the affected segment of the glomerulus. So we call it segmental. So you have a half glomerulus with a pathology. And see, even on immunofluorescence, when they give you like a picture of immunofluorescence, you can easily recognize the focal segmental glomerulosclerosis. You will have a glomerulus with half of the glomerulus lighting up because of the deposits of whatever, it's immune complex or immunoglobulin deposits or complement deposits. This is what's creating the pathology. So when you have a half of glomerulus lighting up by immunofluorescence, so I always say a half, this means that you are dealing with focal segmental glomerulosclerosis or glomerulonephritis. Segmental means half of the glomerulus is having a pathology, and focal means half of the whole glomeruli of the kidney is having the pathology. Less than half of the whole glomeruli of the kidney is having the pathology. So it means that when you look under the whole slide under the microscope, you still see normal glomeruli, and you see some glomeruli which are affected. And when you go high power on these affected glomeruli, you will see that the affection is also involving only half of the glomerulus, not even the entire glomerulus. That's why we call it focal. And when you go high power, segmental. So focal, segmental. Focal means less than 50% of the glomeruli are involved, and segmental means less than 50% of each glomerulus is involved. The focal segmental glomerulosclerosis is happening due to deposits. Deposits of what? Deposits of antibodies and complement. What kind of antibodies and complement? Remember this, IgM. You should make sure that you remember that this is IgM glomerular deposits, because later on we'll see IgG and complement 3 glomerular deposits. And later on we'll see IgA and complement 3 immunoglobulin deposits. So glomerular deposits. So you need to remember each type of antibody and which entity this type of antibody belongs. IgM with complement 3, the first one, we will collect them at the end, the focal segmental glomerulosclerosis. So IgM and complement 3 are depositing by immunofluorescence in focal sclerotic areas or in a half of the glomerulus, lighting up, and on electron microscopy, you end up seeing the same picture of the minimal change disease, which is effacement of the or effacement of the food process. This happened due to 2H and 2-Syk. Remember, the focal segmental happens due to 2H and 2-Syk. 2H include HIV patients and heroin addicts. 2-Syk, sickle cell disease, and sick obesity. Sick obesity means morbid obesity. So I have this like kind of 2-Syk and 2H to remember the causes of focal segmental glomerulosclerosis. The mechanism is unclear. We don't know whether this is immune complex deposits or what exactly is going on. What's the correlation between HIV and this pathology? We don't really know. The pathogenesis is still unclear. On H and E, you will see the focal segmental glomerular involvement, and we already mentioned that. And it usually progresses to end-stage renal disease. It's one of those GNs with bad prognosis. Unlike the minimal change, which had dramatic response to steroids, this means that it has good prognosis. This has bad prognosis, although focal segmental. Okay. Next one is membranous. Very high yield for the boards. And they sometimes give you these pictures, sometimes even come in the RISE exam. This like, what's this stain? Anybody know? Anybody know what's this stain? The one that stains the membrane of the vessels mainly. It's called Jones silver stain. It's called Jones silver stain. Remember this. This is one of the routine stains which are ordered in medical kidney biopsies. Do you have any medical kidney in your program? Like, do you have someone who signs out medical kidneys, or it's sent out?
Yeah, we have 2. I'm not sure 2 or 3. I think 2.
So two attendings in your
2
program.
attendings. Yes.
So do you know the routine stains that they order?
No, I haven't rotated there yet.
You didn't rotate there. What
We
about
have-
Abdurrahman? Do you have?
We have one in the VA, and yeah, she order PAS and silver stain all the time.
Yeah, that's
But
good. These are the two stains that I need to hear. So silver stain and PS, these are two special stains which are routinely done in any medical kidney so that they save time in case they need the Jones silver. They will look at it, or it will be used to confirm some pathologies like membranous. And the PAS is also used to confirm some other pathologies that I will mention later on. So they usually do this routinely. Sometimes based on what they see under H&E and the two special stains, they start saying, oh, I need electron microscope, but they keep a piece of the kidney biopsy. It has a special handling and grossing. I don't know if anybody grossed the medical kidney biopsy before or not. It has a special kind of grossing. You need to keep a piece in this solution for the electron microscopy. What's the name of the solution? Glyceraldehyde, I think. Was it like glutaraldehyde? I think glutaraldehyde, right? I don't remember really, but you need to keep a piece in this solution for electron microscopy and for immunofluorescence. For immunofluorescence, they do it like from this piece that you keep in this kind of solution. You shouldn't put everything in formalin. So I put one piece in formalin and one piece in this kind of solution, so that in case the attending needs immunofluorescence or electron microscopy, he's able to do that. So here is membranous nephropathy. So what do we need to know about membranous nephropathy? The catchy word in the name is membranous. So this means that you are having membranous. Membranous means it's as if you are having a whole membrane, which is present all over the glomerulus. Remember that it's not focal, not segmental. It's all over the glomerulus. See that? See this glomerulus? It all looks as if it has a kind of a thickened blood vessels or thickened vascular spaces, vascular vessel walls, or thickened membrane. That's what membranous nephropathy means, because you have a membrane all over the glomerulus. It has two types, the membranous, primary and secondary. Secondary is more common. Primary is less common, but happen in young patients, which is an autoimmune antibodies, happen in middle age actually, against a kind of a membrane protein. A kind of a membrane protein. You know the phospholipids in the membrane? So it reminds me membranous autoimmune against phospholipase, which is a kind of a phospholipase. It's the enzyme which acts on the membrane phospholipids and enhance the inflammation or start the inflammatory pathway by producing this arachidonic acid. So primary is a kind of autoimmune antibodies against phospholipase, which is like a phospholipid in the membrane. And secondary is happening due to 3 C's. Please remember that. Cancer chemical collagen. I always have this kind of mnemonic for the sake of your CP. If you are going your CP boards. Yeah. So what else has this mnemonic? Cancer chemical collagen, the autoimmune hemolytic anemia. You know the autoimmune hemolytic anemia? Which one, the cold type or the warm type? Anybody remember?
The warm.
The warm type, yeah. The warm type autoimmune hemolytic anemia also happened due to cancer chemical and collagen. This is the second one, which happened due to cancer chemical collagen. Cancers, I mean, it's associated with tumors, those who have tumors or metastatic carcinomas, but mainly it happened in those with blood cancers like leukemia, lymphoma, this kind of things. And chemical means drugs, collagen means collagen diseases like systemic lupus or SLE. The pathology here is kind of immune complex based. So when I say that the pathology is immune complex mediated, this means that you will have granules. Remember, if I say immune complex, so this means you will say granular. Granular, this means that you will see granules lighting up where the immune complex are deposited in the glomerulus under immunofluorescence. So immune complex means granular deposits. The question is, what kind or what's the flavor of the antibody in the immune complex? It's IgG. Sometimes this comes as a keyword, or they label it on the picture. They give you a picture of immunofluorescence with granular deposits and tell you IgG positive. Or they give you that the type of the immunofluorescence antibody that they use is an IgG immunofluorescence. So you need to know that if it's IgGs, it's membranous nephropathy. And if it's IgM, it is focal segmental glomerulosclerosis. So focal segmental is IgM, membranous is IgG. I wish it was the opposite, right? Because IgM will make sense that it's membranous M with a M, but I'm a little bit unlucky in this. So it's IgG, granular deposits, membranous nephropathy. IgG C3, granular deposits on immunofluorescence. So these immune complex deposits, please remember, what's immune complex? Immune complex is an antigen antibody complex, which is circulating in the peripheral circulation. This kind of antibody is like a bomb. This immune complex is like a bomb. Wherever it settles, it damages. Wherever it settles, it damages. Why? Because wherever it settles, it will bind the complement 3, which is the complement factor responsible for clearance of the immune complex. And this complex 3 is going to activate the complement pathway and recruit inflammatory cells to the area. Once the inflammatory cells get recruited to the area, they try to get rid of this immune complex. But unfortunately, due to the ongoing fight, what happens is also there is kidney injury or injury in the glomeruli and the podocytes, which will happen. See, so immune complex deposits which activate the complement, causing podocytic damage. The podocytic chronic damage which happen in the podocytes will make a kind of reactive healing. You try to heal, so you try to deposit or reactive membrane production and deposit new membrane in order to heal, because this is a chronic damage. And this is what leads to this membrane or the thickening of the membrane that you see on H&E. And see, when you do Jones silver stain, the new membrane deposits or the membrane deposit, the reactive membrane deposits will look like spikes around the lumens. Lumens with spikes. I always say spiky lumens. It's like when you put some gel and you make your hair stands up like a spike. This is, like I always say, spiky lumens. The spiky lumens on Jones silver stain is due to the reactive membrane production that happened due to injury of the podocytes. On H&E, you have diffuse sclerosis, diffuse thickening of the membrane, and on electron microscopy, you will see the immune complex deposits. See, here it is. This electron dense areas are the immune complex deposits. And in between these immune complex deposits, you will see the spikes, the membrane spikes, or the reactive deposition of the membrane, which happened due to the chronic damage. They call it subendothelial dense deposits. Subendothelial. Remember this subendothelial, because I will mention another type of glomerulonephritis where you will have subepithelial deposits. Subendothelial means the deposits are mainly on the endothelial side of the glomerular basement membrane, because as you remember, I hope that everyone remembers that. I'm sure that everyone remembers that. If I open the whiteboard here, like what you see in the glomerulus is this Bowman capsule, and you have the afferent arteriole, and then you have the efferent arteriole. If you click on the board, you'll end up putting your name. See, we have like Muhammad walking around here. I can disable that, but it's fine. So just you have the afferent artery, and then you have the glomerulus and the efferent artery. If you zoom in here by electron microscopy, you will find the glomerular filtration barrier, which include two lumens. That's the lumen of the blood vessel, and that's the lumen of the Bowman capsule. So you have the endothelial cells lining the blood vessel here on one side, and you have the podocytes here on the other side, and the epithelial lining of the Bowman capsule, of course. And then we have the basement membrane of the endothelium and the basement membrane for the epithelial cells lining the Bowman capsule. Both of these basement membranes kind of fuse together, and they form a thick layer of glomerular basement membrane. So we have the endothelial layer here is layer number 1. And you have the fused basement membrane, which is the GBM, which is layer number 2. And we have the podocytes and the epithelium of the Bowman capsule, which is layer number 3. Where can we find the filtration slits? In layer 1, 2, or 3? Can anybody tell me? Yes, good job, Mohammed. He pointed to the to the layer number 3. So layer number 3 is where we will find the filtration slits. Here, it's right there. So here is the key now. So in in membranous glomerulonephritis, you have deposits, immune complex deposits. It's subendothelial here on the endothelial side of the glomerular filtration. Subendothelial here. We will have another type of glomerulonephritis where there is also immune complex deposits, but it's subepithelial on this epithelial side. So you need to identify whether it's subendothelial, subepithelial. It helps you differentiate between the two types. Sharing your screen will close the whiteboard for everyone. Yet continue. Okay, so that's what they mean by subendothelial dense deposits. So here are the deposits. The deposits here are subendothelial. Here's the membrane spikes. Please memorize this picture. Very important. Memorize also this spiky lumens of Jones-Silverstein. This picture is also important, membranous nephropathy. Then the diabetic nephropathy is the last one for the nephrotic syndrome. It happens in patients with diabetes. Not any patient with diabetes. It's the one who doesn't control his blood sugar very well. So poor control, long-term poor diabetic control. For the pathogenesis, we need to talk about it a little bit. But you need to remember from the pathogenesis of diabetic nephropathy that it's not heavy proteinuria from the beginning. It doesn't start as heavy proteinuria right away. And I believe that most of you guys remember that. So let's open the whiteboard again. And let me see. Here is my classic presentation for the pathogenesis of diabetic nephropathy. I believe some of you guys heard that when I was explaining the USMLE in the pathology section. Here is the epithelial lining of the tubules. And here is the afferent arteriole. Here is the glomerular capillary. Here is the efferent arteriole. So the blood enter from here. Some of the elements get filtered from here, and then it leaves from there. Okay, so what happened in diabetic nephropathy is diabetic angiopathy. With uncontrolled diabetes, there is a kind of angiopathy. The uncontrolled blood sugar starts affecting the vessel wall, and the pathology usually starts in the efferent arteriole before it involves the afferent arteriole. The narrowing starts first in the efferent arteriole before starting in the afferent arteriole. Narrowing of the efferent arteriole here will lead to congestion of blood here. The blood will remain stagnant here because it enters and it doesn't leave as well as it used to leave before. So it starts accumulating here. This increases the hydrostatic pressure. So what will happen to the GFR? It will increase. That's in the initial stage of diabetic nephropathy. Initial increase in GFR. The initial increase in GFR will lead to filtration of some blood elements which never used to be filtered before, which are the proteins. So this will lead to proteinuria. The proteinuria will start as mild in the beginning, and then it becomes severe eventually. So we have proteins which are getting filtered here. Proteins, when they get filtered, they start irritating the tubular epithelium. This leads to tubular epithelial chronic inflammation, which lead eventually to chronic nephrosclerosis. The nephrosclerosis lead to tubular obstruction, tubulosclerosis. This leads to tubular obstruction, and the tubular obstruction will lead to decrease in GFR, because now the filtrate is getting filtered into an obstructed tubule. So eventually the GFR will decrease, and this will lead to diabetic renal failure. Okay, that's the pathogenesis of the diabetic nephropathy. And that's why you need to remember that the proteinuria doesn't start as heavy from the beginning. Okay, so let's go back to our presentation. So here is the pathogenesis. I already explained the pathogenesis of diabetic nephropathy. And you know that it doesn't start as heavy proteinuria from the beginning. The pathology here, we will have some kind of vascular thickening. The vascular thickening means mesangial thickening, because most of the blood vessels exist in the mesangium. So you will have increase in mesangial matrix with vascular hyalinosis. This is the key pathology that we'll see. The increase in mesangial matrix with vascular hyalinosis will present as nodules in the glomerulus. Nodular glomerulus. I always say nodular glomerulus. Diabetic nephropathy means nodular glomerulus. Even this increase in mesangial matrix and increase in collagen and the vascular hyalinosis, which happen in can stains with PAS, you can stain that with PAS and highlight these nodular or highlight these nodules in the glomerulus. What are these nodules used to be called? KW nodules. Anybody know what it stands for? Anybody remember what it stands for, these nodules? What's the name? KW?
Kimsel-Wilson or something like that.
It's what?
Something-
Kimsel?
Yeah, Kimmelstein-Wilson. Kimmelstein-Wilson nodules. It's called KW nodules. I always say Kimmelstein-Wilson nodules, or I always say keyword nodules, because it's a keyword for diabetic nephropathy. So remember that these nodules on H&E of mesangial expansion and sclerosis are pathognomonic for diabetic nephropathy. You might do PAS stain to highlight the vascular hyalinosis and highlight the nodules. And if you do electron microscopy, although it's not high yield, you will see a diffuse membrane thickening here. See how the membrane is extremely thickened, but it's not nodular. There is no like deposits, nodular deposits. There is no spikes. You just have a diffuse thickening of the membrane. This is what happened under electron microscopy. So diffusely thickened basement membrane. The significance of having diabetic nephropathy is this means that you are having an uncontrolled diabetes. The sugar is not controlled enough, and it usually develops concurrently with diabetic nephropathy. Add this fact to Kurt notes. It's not there. Add this fact to Kurt notes. It was asked in 2 Q banks that when you see this kind of change, this means that there is diabetic nephropathy going on at the same time. It's associated with diabetic nephropathy at the same time, from eye pathology, of course. Okay, eye pathology is very low yield for the boards. That's it for the nephrotic syndrome. So minimal change in pediatrics due to drugs or infections. Selective proteinuria, minimal change means no change on H&E and effacement of food process of podocytes by electron microscopy. And focal segmental, it's focal segmental, half of the glomerulus is lighting up by immunofluorescence. It's IgM deposits, remember that, and it's associated with 2H and 2-Sick, HIV, heroin, and sickle cell sick obesity. It usually progresses to end-stage renal disease and associated with effacement of food process under electron microscopy. Membranous, it's immune complex mediated, usually secondary, maybe primary antibodies against phospholipase, M or M-type phospholipase, which exist in the phospholipid membrane, makes sense with membranous, or the 3C's cancer chemical collagen with immune complex deposits causing complement activation and podocytic and GBM damage and reactive membrane production, which lead to spiky appearance by Silverstein-Jones. Jones-Silverstein shows spiky lumens, and there is immunofluorescence, shows granular deposits. Remember that the deposit here is IgG. And on electron microscope, you will see the granular deposits and the membrane spikes in between. Diabetic nephropathy, the nodular glomerulus by H&E, highlighted by PAS. It happens due to affection of the blood vessels and the mesangium due to chronic uncontrolled diabetes, and it's highly associated with diabetic nephropathy. That's it for the nephrotic syndrome. Any questions? Thumbs up if you are still awake. Okay, so I have Mariam awake, Alia awake, okay, perfect. So nephrotic syndrome, as you remember, acute damage, it's acute glomerulonephritis. So mainly it presents as significant hematuria, and hematuria means RBCs in urine and RBC casts in urine. Casts means like deposits. There is the types of casts in urine. I believe you need to know that for the CP, but I don't have really a CP, that much CP background because I'm AP only. So acute glomerulonephritis with RBCs and RBCs casts in urine. However, there is mild proteinuria, mild edema. This is an acute inflammation, means that you will have neutrophilic glomerular infiltrate or diffuse and scary glomerular damage. Here are the disorders that you need to memorize for your boards for the nephrotic syndrome. Acute post-streptococcal glomerulonephritis. Rapidly progressive glomerulonephritis looks scary. Acute is scary. And then the AB syndromes, A for Alport syndrome and B for Berger disease or Berger syndrome, which is IgA nephropathy. Let's start with the acute post-streptococcal glomerulonephritis. It happens, of course, usually in pediatric population, and I'm sure you guys remember that from your step 1. I might end up explaining it in the microbiology lecture in a while, which is group A beta hemolytic streptococcal infection. Starts with infection by GABS, which are group A beta hemolytic streptococci, which includes Streptococcus pyogenes. However, please memorize or remember that now it happens post-staphylococcal infection or post-staph, not post-strept. You know why post-streptococcal infections decline? Due to penicillin prophylaxis. Usually when they have a patient or when they have a kid with history of acute post-streptococcal glomerulonephritis or rheumatic fever, they will end up putting him on penicillin prophylaxis until he becomes an adult. So this protects him against GABS. However, it doesn't protect him against staph that much. So they end up developing the same APS-GN, but post-staphylococcal, not post-streptococcal. So staph infection is now more common in terms of APS-GN. What happens here classically, as you know, that the bacteria, the group A beta hemolytic streptococci, it produced this protein M, which is one of the antigens that the bacteria produce. The antibodies against protein M will bind. This will make an immune complex, like a circulating bomb in the circulation. It deposits on the glomerular basement membrane from the epithelial side. They deposit mainly on the epithelial sides. They get filtered and deposit on the epithelial side. See? Subepithelial humps, subepithelial deposits. So if I'm talking about immune complex deposits, please remember that this means granular pattern on immunofluorescence, granular pattern on immunofluorescence, and lumpy, pumpy pattern on electron microscopy. But you need to focus whether this is at the epithelial side or at the endothelial side. This is subepithelial deposits of immune complex. Wherever the immune complex deposit, this leads to activation of complement 3. Once complement 3 gets activated, it recruits the neutrophils, and this leads to glomerular basement. This is an error. So you have glomerular basement membrane and podocytic damage, and neutrophilic infiltration and acute inflammation. Here is the key. On H&E, what you see is an enlarged hypercellular glomerulus. See how this glomerulus is very busy, very crowded, very hypercellular. And if you go high power, you will appreciate some neutrophils there. So enlarged hypercellular glomerulus with neutrophilic infiltration. And then on immunofluorescent, we'll have granular pattern or granular immunofluorescent deposits. What kind of antibody is there? It's IgG. Like which one? Like which disease we had before? They have IgG.
Membranous.
Membranous. We said that we are unlucky that membranous is not IgM, so this means that membranous is IgG. So IgG complement 3 complex subepithelial, not endothelial deposit. In membranous, it was subendothelial with membrane spikes. Here it's subepithelial granular deposits. Even it's confirmed by electron microscopy. The prognosis here is age dependent, with good prognosis in pediatrics, but bad prognosis in adults. You'll have this question, but in USMLE, not in the boards. The USMLE asks this question, like the prognosis is age dependent, but we don't really care much about prognosis. We care about diagnosis in pathology. So you might get one of these pictures in your boards, the enlarged hypercellular glomerulus or the granular deposits, and they tell you that this is IgG, and the patient is, for example, having mild proteinuria. This means that nephrotic syndrome with IgG deposits, granular deposits. So I'm talking about acute post-streptococcal glomerulonephritis. This is the lumpy pumpy deposits. I often say that I see the same thing here. What do you see here? What do you think? What this is? I potentially see the same thing here. What do you think about this? Can anybody comment about what I highlighted right there? Here. Look at this, the laser pointer here. It's a kind of a membrane spike, actually. So please, they're potentially the same pathogenesis as the membranes, but it's happening on the other side of the it's on the other side of the glomerulus. It's happening on the epithelial side. The other one was happening on the endothelial side. However, they will definitely give you some keywords that the patient is having, like nephretic, patient is having nephrotic. So you kind of have a keyword which will let you go towards one versus the other. Okay. Rapidly progressive glomerulonephritis. It's very scary. It's rapidly, yeah. It happens rapidly, honestly, and the patient end up within weeks start like doing this kind of having like acute renal failure within weeks. So it's rapid, yeah, it's rapid clinical onset with severe nephritis or with severe nephretic syndrome, and very progressive. It usually has poor prognosis and progress rapidly to acute renal failure. It includes two entities, both of them leads to the same outcome, which is rapidly progressive glomerulonephritis. When I look under the microscope, how can I tell that I'm having a pattern of rapidly progressive glomerulonephritis? You see this. Glomerular crescent, very important. Glomerular crescent. Here is the crescent, the structureless, damaged area of the glomerulus. compressing the remaining healthy part or the remaining relatively healthy part of the glomerulus, which is actually almost gone. It's gonna be gone in a while. But you will see this crescent, the structureless necrotic area of the glomerulus, which we call glomerular crescent by H&E. Very high yield, very important picture. This crescent is usually made of necrotic tissue plus fibrin plus some monocellular infiltrate like monocytes, macrophages, some inflammatory cells, and these kind of things. That's crescent formation. When I see crescents, well, that's rapidly progressive glomerulonephritis. Now you start looking at the patient history, because these are two possibilities. That's either anti-GBM disease, anti-glomerular basement membrane disease, or what they call post-immune glomerulonephritis, which is ANCA positive autoimmune glomerulonephritis. Why they call it post-immune? Anybody know? Post-immune. Anybody have any idea why they call it post-immune? Any guess? Because it doesn't light up on immunofluorescence. Based on my knowledge, it doesn't light up on immunofluorescence. You don't have that diffuse linear membrane deposit on immunofluorescence. So that's why they call it post-immune glomerulonephritis. This kind of glomerulonephritis happened due to autoantibodies or autoimmune antibodies against the neutrophils, which called ANCA, anti-neutrophil cytoplasmic antibodies. These ANCA antibodies lead to neutrophilic activation. The neutrophils become activated, become hyperactive, and they start attacking the kidney aggressively. That's what happened. You have two types of post-immune glomerulonephritis or ANCA positive GN. It's one with a positive P ANCA and one with a positive C ANCA. P ANCA is when you have this perinuclear deposits or perinuclear immunofluorescence lighting of the neutrophil. See, it's as if it's highlighting the nucleus, right? You see that? Give me a thumbs up if you see it, or if you, yeah. No problem. So here it is. See, you can see this perinuclear and perinuclear immunofluorescence lighting up. That's what I mean by P ANCA, perinuclear. But here, see, the nucleus is nearly dark, and you see that what's lighting up is the cytoplasm. That's why they call it cytoplasmic ANCA, or cytoplasmic anti-neutrophil cytoplasmic antibody. And the other one is called perinuclear anti-neutrophil cytoplasmic antibody. You need to memorize for your boards what's the flavor of each. Like the P ANCA is MPO. The P ANCA is MPO. It's antibody against the MPO of inside the neutrophils. It's anti-MPO antibody. So P ANCA is MPO, and it's usually positive in what we call Churg-Strauss syndrome. I saw people like pronouncing it differently, Churg-Strauss, whatsoever. So this is the syndrome which had the positive P ANCA and might lead to RPGN, or rapidly progressive glomerulonephritis. However, the C ANCA is anti-PR3 or PR3 antibody. You need to memorize what kind of antibody is the C ANCA, and it's usually there in one of the famous vasculitis diseases, which we call Wegener or Wegener granulomatosis. It depends whether you will pronounce it in German. I think in German it's Wegener. In English, it's Wegener. So Wegener granulomatosis or Wegener granulomatosis, C ANCA positive. Churg-Strauss is P ANCA positive, and PO. Memorize these. It's IgG, antibody deposits with complement 3, IgG with complement 3, and this is the post-immune. What about the anti-GBM disease? Anti-GBM disease is famous. It's Good-Pasteur syndrome. Good-Pasteur syndrome is a famous patient with blood in the lungs, blood in the kidneys. I always say blood in the lungs, blood in the kidneys, because of autoimmune antibodies against collagen type 4. And collagen type 4 is the one that exists in the basement membrane. Anybody remember the mnemonic? Collagen type 4 is on the
Floor.
Yeah, collagen type 4 is on the floor. Floor is the basement membrane over which the epithelium sits or over which the epithelium stands. So collagen type 4 is on the floor. So it's autoantibodies against collagen type 4, which exist in the basement membrane. This leads to damage or acute damage, which will mainly involve the organs whose function relies mainly on an intact basement membrane, like the lungs. And that's why you have hemoptysis and blood in the lungs, alveolar hemorrhage. We will see that in medical lung as well. And you have rapidly progressive glomerulonephritis in the kidney with acute nephritic syndrome and rapidly progressive nephritic syndrome with hematuria or blood in the urine. So blood in the lungs, blood in the kidneys due to autoimmune reaction against collagen type 4. And immunofluorescence, very important for the rise, very important for the boards, very important for everything. You have this linear immunofluorescent deposits or linear IF deposits of IgG and complement 3. What is the skin disease which has the same pattern? Linear immunoglobulin deposits. Skin disease have linear immunofluorescence deposits, which might be subepithelial on the basement membrane or interepithelial in the skin layers. Bemphigus. Remember that bemphigus and bullous bemphigoid. Bullous bemphigoid, you have it on the basal layer of the skin, and you have also linear deposits in between the epithelium in the bemphigus vulgaris, and the bullous bemphigoid, you have it on the basement membrane. I'm just trying to try to stimulate the brain. So it's anti-GBM disease or post-immune glomerulonephritis. The end result is rapidly progressive glomerulonephritis with glomerular crescents and acute kidney damage, acute renal failure. Very bad. What about the IgA nephropathy? What's IgA? Anybody know? What's immunoglobulin A? It's the one which exists in
Secretions, like
yes,
tears.
yes, like secretions. It's the one which exists in secretions, like the saliva, like the mucus, like anything. So that's why it's the most prominent antibody type which exists in tract immunity, surface immunity on the tracts, in GI tract, respiratory tract, whatsoever. So what happened in IgA nephropathy? What happened is a patient get a tract infection, GI tract infection, respiratory tract infection, whatsoever. And the problem is his immune system overproduce IgA to the point that it floods in the circulation. And there is elevated IgA in the circulation. That's why we see elevated IgA in the circulation. And it start making immune complex with the complement and deposit in the mesengium, causing mesengial expansion and mesengial deposits with granular, or I would say map-like pattern. I always say map-like because you know why map-like? Because this is where mesengium exists. Mesengium is the kind of interstitial tissue of the glomerulus. So it doesn't exist everywhere. Like these areas are blood vessels, see? These areas with lumens are blood vessels. What exists in between these blood vessels is what we call the mesengium, and it has some kind of cells called mesengial cells or mesengial matrix and mesengial cells. So here the IgA deposits are mainly in the mesengium, and that's why it lights up in the mesengium by PAS stain. It lights up in the mesengium and you see a map-like pattern in the glomerulus. And You have the same map-like pattern on immunofluorescence. And you are lucky if they give you a keyword and tell you that they are using immunoglobulin A antibody here on the immunofluorescence. So you are lucky enough. Oh, does this mean that this is immunoglobulin A deposits in a map-like pattern in the glomerulus? This is due to overproduction of IgA in response to a tract infection, leading to immune complex deposits in the mesangium with reactive membrane proliferation like membranous nephropathy, potentially the same thing. However, the pathology here is mesangial on H&E, MPAS, and on immunofluorescence and electron microscopy. It's highly associated with a kind of vasculitis, very important. It's this Henoch-Schönlein purpura. If you're planning also to pronunciate it in German, Henoch-Schönlein purpura. Henoch-Schönlein purpura is a kind of vasculitis which happened due to IgA deposition in the blood vessel walls. And this leads to what we call palpable purpura, if you remember, which happen in the lower half of the body in pediatric population, those who are having IgA nephropathy or what we call Berger disease. It's IgA, A, and it's common in Asia. Okay? So now let's memorize. Immune complex deposits, IgM. What is it?
Focal segmental.
Focal segmental. And immune complex, IgG. What is it?
One of them is
Let's see, Seham, go ahead.
So membranous. That's what I.
Membranous. And what else?
And then we also have.
Remember.
Oh yeah, post.
Rapidly progressive. Rapidly progressive as well. You have this IgG, linear immunoglobulin deposits, or IgG immunoglobulin deposits, also in acute post-streptococcal glomerulonephritis. So acute post-streptococcal glomerulonephritis and also membranous, all right? And what about IgA? Immune complex deposits, it's IgA nephropathy. So collect the immune complex deposits and flavors in medical kidney and make like a collection for yourself while you are studying. Put it aside or put it on the back of the paper in Kurt notes so that you have the collection and you keep like hitting this multiple times with your eye. This will help you out when you solve the questions. It sticks. Alport syndrome. Anybody remember what else we saw this kind of cells before in renal tumors?
This is the macrophages between the papillae and the renal cell carcinoma with papillary.
Yeah, the classic papillary. The classic papillary RCC, not the clear cell papillary RCC. The classic papillary RCC had this foamy macrophage, the same interstitial foam cells or interstitial foamy macrophage. But here, this time, it's there even in the interstitium of the kidney, by the way. It's not in the glomerulus. Because you see here, can you see this tubule? You can see this renal tubule actually, but it's just interstitial foam cells in between healthy renal tissue. There's no cancer there. There's no cancer. You still see the tubules, you still see the things look very benign, but you see these accumulations of foam cells in the interstitium for some reason. This is Alport syndrome. Alport syndrome is X-linked dominant syndrome because of defect in collagen type 4 synthesis or collagen type 4 formation. And this leads to affection of the glomerular basement membrane and injury eventually to the GBM, which will present as nephretic syndrome. The patient have the classic triad, which I can't see, I can't pee, and IMD. I can't see, I can't pee, and IMD is different from I can't see, I can't pee, I can't climb a tree. Yeah, does anybody remember I can't see, can't pee, can't climb a tree? Anybody remember what this?
That's 27.
Actually, it'd be 27, but what's the name of the disease? You remember?
Not really. I just remember the difficult part.
Reiter syndrome or reactive arthritis. The Reiter syndrome or reactive arthritis, which is one of the seronegative spondyloarthropathies. Anyway, but you have can see, can P, can climb a tree, and now we have the can see, can P, IMD. Can't see because the patients will have corneal clouding because of problems with the basement membrane of the corneal epithelium. They will have loss of renal functions, can't P, because of the nephritic syndrome, which happen, and IMD because of sensory neural hearing loss, because they have problems with the basement membrane of the hair cells in their inner ear, which are responsible for hearing. That's why they have sensory neural hearing loss. On H&E sections, you will see these interstitial foam cells, and on electron microscopy, you will see torn, splitted glomerular basement membrane. You see that? That's how a splitted basement membrane looks like. It's torn, ragged, splitted, laminated basement membrane because of defect of collagen type 4, of course. That's the Alport syndrome. There is another rare entity. I never saw it in the questions, honestly. It's called thin basement membrane disease. It's kind of a variant of Alport. They always say this is Alport syndrome, but localized in the kidney only. So it's isolated kidney Alport syndrome. It doesn't have this corneal clouding and doesn't have sensory neural hearing loss. It's also mutation in collagen type 4 genes, COL4A, COL4A3, and COL4A4 genes. But this is autosomal dominant, not X-linked dominant as the other one. And usually what you have is just microhematuria or persistent hematuria. They call it benign familial hematuria. And actually, this never progressed to nephritic syndrome, and it never progressed to renal failure. They just live with some blood in their urine. And on electron microscopy, you will see how the difference is between the normal basement membrane on the upper side and the thin basement membrane on the lower side. See, this is how thick the basement membrane should be. This is the fused basement membrane of the podocytes from one side and the endothelium from the other side, as I explained before on the whiteboard. Let's go over the hints or the hits. Let's exercise. Who want to go with number? We have 7 and we have 14, so we need each one. I don't count, so we have 6. So we need each one take 2 at least. So let's go one by one. Abdurrahman.
First one is focal segmental glomerulosclerosis. Second one should be nodular. Oh, nodular.
Himmelstein Wilson nodular.
Yeah, diabetic.
Okay, so I helped you. It's diabetic nephropathy. All right.
Well, okay, spikes is subendothelium, so that's
nephropathy. And IgM, complement 3 deposits. You mentioned this is focal segmental glomerulosclerosis. Good job. Okay, so next is Alia.
Spikes is membranous
Membranous.
and linear
And
IgG.
in membranous, what type of antibody or immunoglobulin is there in the immune complex? Do you remember?
Membranous IgG, yes.
IgG. Okay, so it's IgG, not IgM. All right, and then you have number 4, linear IgG.
Linear, the good pasture, the crescent, rapidly progressive, yes.
Good-Pasteur syndrome, rapidly progressive glomerulonephritis, which have crescents on H&E, right?
Yes.
Okay. Next in the line, Siham.
Okay, subepithelial deposits. Okay, subepithelial or subendothelial? Okay, subepithelial. Okay, so a subepithelial is post-strep.
Post-streptococcal glomerulonephritis. Are you sure?
Yes.
Acute post-streptococcal.
Yes.
Okay, acute post-streptococcal glomerulonephritis. We will double check. And then the subendothelial is?
The membranous.
The membranous.
Subendothelial. Yeah.
Okay. Correct, but let me double check. Here we go. So we
No,
got
she is right.
it's what? It's the opposite. Acute post-streptococcal is subepithelial. You mentioned that, right? Or
Yes.
subepithelial. Yeah, you are correct. So then you are correct. Acute post-streptococcal is subepithelial, and the membranous is subendothelial. And remember that both of them would have this kind of spikes. So don't just rely on spikes. I feel like it exists in both. But you will have the lumpy, pumpy deposits on electron microscope or electron microscopy with some intermembrane spikes because of reactive membrane healing or attempts of reactive membrane healing. So next is Dina.
Okay, we have the granular deposits that for the membranous
Membranous
and
else, so I need two.
and the acute streptococcal glomerulonephritis.
Acute post-streptococcal glomerular, well, makes sense. Yeah, acute post-streptococcal have granular pattern because both of them has the immune complex deposits. We mentioned subepithelial, subendothelial, so both of them will have granular appearance or immunofluorescence. Okay, but what else also had mesangial pathology? Two diseases with mesangial pathology.
I remember the IgA,
IgA
but then the second one, what was
is
it?
diabetic nephropathy.
Oh, yes, the diabetic, yes.
There is mesangial expansion in diabetic nephropathy as well. So remember that. The IgA had a kind of map-like pattern. Remember that? Map-like pattern. Okay.
Okay.
Okay, next is Muhammad.
We're now crescent. Crescent formation is the rapidly progressive glomerulonephritis, right?
Rapidly progressive glomerulonephritis, which include good pasture syndrome and what else?
Good pasture and what was the other one? I forgot. Posse immune, yeah.
Posse immune, which has the Pianca and
Cianca and Cianca, yeah.
Okay, Pianca is for the church spots,
yeah.
and the Cianca is for
Posse, right?
the Wegener granulomatosis.
Wegener,
You have Pianca, Cianca. It's a
Yeah.
lot of memorization, I know, but you know, this is what we need to. That's why
Yeah.
I'm putting this one. So the other one, IgA, easy. IgA complementary deposits.
Is it the burgers thing?
Yeah, the
Burger. I'm hungry.
Yeah, IgA. Yeah, I always say, you know, when I explain it, if you remember Dina from the USMLE, when I say burger is different from burger. There is another disease called burger, you know, and the difference is just one letter. The burger is the kind of vasculitis which happen in smokers and lead to the fingers fall off with gangrene. You know that this peripheral vasculitis. So burger is different from burger. So next is Hiba. The last. Oh, you don't have a microphone. I don't see any.
Wait, now I can.
Oh,
I
yeah,
can-
now
can
you
you
have
hear
it.
me?
Okay, good. I can hear you now. So, Emma, what's a interstitial foam cells?
That's Alport.
Alport syndrome. Yeah, good job. And anti-collagen type 4 antibodies.
That's also Alport and GBM.
GBM, which is the GPS, you mean, good pastor syndrome.
Oh, gross.
Yeah, GPS, it's good pastor syndrome. GBM is glomerular basement membrane. So GPS is a good pastor syndrome. But just letting you know, Alport syndrome is not anti-collagen type 4. Alport syndrome is defect in collagen type 4 synthesis. But there is no autoimmune reaction to collagen type 4.
Okay.
It's X-linked dominant. Okay? Anybody have any questions? Any questions? Everything is good? All good? So I will see you next session. Next session is gonna be tomorrow. I will finalize the medical kidney. We will finish the medical kidney, finish the genitourinary tomorrow. Make sure you put in your vote for the next specialty, because we will start the next specialty over this or before this weekend. Okay. Thank you very much. Nice to meet you. Wish me luck in my next session because I have a session in like 20 minutes or so. Another lecture. Thank you very much. I appreciate it. Enjoy your day. Have a good night.
Good night. Good night.
Good night. Bye bye.
Good night.
Bye-bye.
Thank you.
Thank you.
Thank
Thank
you.
you.